Good afternoon and welcome to today's webinar, Health Justice, Homelessness and Sanitation, Confronting a National Public Health Crisis, brought to you by the Network for Public Health Law and the American Society of Law, Medicine, and Ethics. I'm Charles Chong, the Digital Marketing Coordinator at the Network for Public Health Law's National Office, and I'll be your host for today's webinar. Please feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the Ask drop-down menu, and submit your question. Your moderator for today's webinar is Corey Davis. Corey is the Deputy Director at the Network for Public Health Law's Southeastern Region Office and a Senior Attorney at the National Health Law Program. His work focuses on identifying and leveraging legal and policy initiatives to address the opioid epidemic. Corey will be leading us through the rest of today's webinar, so Corey, over to you.
For Public Health Law and Policy at Arizona State University's College of Law. Her research and practice focus on providing legal and policy solutions to today's most urgent health justice issues, aiming to increase equity and action on the full range of social and structural forces that shape population health. We're also joined today by Greg Spiegel. Greg is Inner City Law Center's Director of Strategic Initiatives. The Inner City Law Center provides free legal services to help people get housing and keep that housing. Greg's work focuses on advancing public policies that seek to end and prevent homelessness. And last but not least, we've got Lauren Dunning. Lauren is a liaison to the Board of Supervisors for the LA County Department of Public Health. She manages departmental responses to policy and programmatic requests on emerging priorities related to public health. Lauren previously served in policy and planning roles at the Los Angeles County Department of Public Health, where her work focused on developing policy strategies for reducing the burden of communicable and chronic diseases within the county, particularly on efforts to increase access to healthy foods in retail environments and legal responses to communicable disease threats. So with that, I'm going to turn it over to Madeline.
Thanks, Corey, and thanks everyone for joining us today. I'm excited to talk about what I mean when I say health justice, how shortfalls in equitable sanitation and hygiene access helped fuel the worst multi-state hepatitis A outbreak in over 20 years, and legal and policy strategies that jurisdictions can leverage to promote equitable access to these basic public health services, advance health justice for people experiencing homelessness, and catalyze far-reaching population health improvements. I want to take just a couple of minutes and offer health justice as an important framework for thinking about these issues and crafting solutions. Professor Lindsay Wiley at American University's Washington College of Law has suggested 3 interrelated health justice commitments for the use of law as a tool to fight health inequities. The first commitment is about putting healthcare in its place. It's about broadening the scope of our inquiry and action on health inequities to address the full range of determinants that shape population health. The second commitment runs counter to dominant approaches that tell individuals to change their behaviors while neglecting the social and structural forces that limit their ability to do so. It's about advancing collective responsibility for the forces responsible for health inequities. The final health justice commitment centers on moving beyond expert-driven agendas toward collective action and participatory engagement. This is about empowering communities to address the very issues that undermine their health, liberating them from often intergenerational cycles of social oppression and even political exclusion. It's about the inherent right of populations to protect themselves from the forces that undermine their health, the right to act together to ensure essential needs are met. We'll keep these commitments in mind as we examine the root causes of the public health crisis before us and explore equitable legal and policy solutions. That brings us to the worst multi-state hepatitis A outbreak since before the FDA approved a vaccine in 1995. This map captures states and localities where major outbreaks have been confirmed since 2016. In 7 states alone, we've seen over 3,000 cases and 55 deaths. Hepatitis A is a highly infectious but preventable liver disease spread person to person and through contact with contaminated food and water. For those of us who are privileged and in good health, stable health care access and healthy living environments, hepatitis A is often a mere inconvenience, but for those of us who are less well off, it can be life or death. We've seen disproportionate impacts on community members living in extreme poverty and with chronic conditions, particularly people experiencing homelessness and people who inject drugs. Today, we're going to focus specifically on how this preventable crisis is harming people experiencing homelessness and what we can do about it through law and policy. On a single night in 2017, 3,000 of the total population in California experienced homelessness, about 134,000 people. Yet, when my team obtained data from the California Department of Public Health on the state's hepatitis A emergency, we found that 52% of those diagnosed with hepatitis A, 61% of those hospitalized, and 71% of hepatitis A-related deaths in California between 2016 and 2018 affected people experiencing homelessness. If you said that these disparities were about inadequate access to health care, the fact that our national vaccine supply was too low to meet needs in the outbreak, you'd be right, but when we look at the root causes of the health justice issue before us, we see that it is about so much more than health care. In communities nationwide, adequate, safe, clean, and accessible public sanitation and hygiene facilities, that is, public toilets, hand sinks, showers, and laundry facilities, are scarce or altogether absent. As Greg's going to talk about in a bit, these shortfalls are measurable and disproportionately affect people experiencing homelessness, especially the 1 in 3 people experiencing homelessness without shelter on any given night. In the absence of these services and the safety and dignity that they provide, people experiencing homelessness face physical and behavioral health risks that are unimaginable for most of us. Lack of access can force people experiencing homelessness without shelter to urinate and defecate outdoors and forego hand washing, showers, and clean laundry. People who menstruate face additional difficulty obtaining, changing, and disposing of sanitary products. These shortages leave people experiencing homelessness living in unhealthy environments, contaminated by human waste, and thus vulnerable to hepatitis A virus, meningitis, staph infection, lice, and a whole range of other physical and mental health harm. Public toilets were once considered a public good. John Snow, the father of epidemiology, fought cholera by changing the water and waste systems of London, revolutionizing public health forever. In fact, the British Medical Journal named the sanitary revolution the greatest medical advance since 1840. But today, it's like we're going back in time. We're seeing public works and other local authorities closing down services around the country. According to CityLab, New York City had 1,676 public toilets in its subway system in the 1940s, yet only 77 remained by 2013. We're also seeing that many public toilets have limited hours of operation and are not adequately maintained. This is more than merely problematic for people experiencing homelessness who have to use the toilet during the night, just like the rest of us who are stably housed. Numerous state and local laws prohibit human excretion and indecent exposure in public places and impose costly civil or criminal penalties for violations, including incarceration. These measures are discriminatory and ineffective, especially when the conduct is an unavoidable consequence of experiencing homelessness without shelter. They're also expensive, costing municipalities hundreds of thousands of dollars in direct and indirect costs to enforce that could instead be invested in public sanitation and hygiene solutions. Likewise, programs that aim to deter public urination and defecation can be discriminatory and ineffective. For example, a 2015 pilot program in San Francisco coated 9 city walls that were frequently urinated upon with a special paint engineered to forcefully deflect urine back onto a urinator's pants and shoes. Imagine for a moment relieving yourself outside because you have nowhere else to go and having your own urine splash back at you without any hand sink, shower, or laundry facility to clean up. But perhaps most illuminatingly, we saw that local governments generally lack a structure for ongoing collaboration and communication on these population health issues. As a result, public works, health services, human services, and law enforcement agencies, among others, often think in their own lanes instead of considering the interdependencies, inefficiencies, and health equity impacts of policies across sectors. This disconnect makes it difficult to respond to related disease outbreaks in the most effective and efficient way possible. But it's more than public health emergency preparedness and response. More importantly, the disconnect in our system means policy actors often unknowingly exacerbate barriers and miss opportunities to improve public sanitation, hygiene, and health. So, how can public health law and policy advance equitable sanitation and hygiene access for people experiencing homelessness? To answer this question, my team explored how jurisdictions in the United States and around the globe are advancing access. We also worked through analogy, identifying legal and policy solutions to other public health problems, like food insecurity, that can be translated to address these issues. Based on our findings, we produced an issue brief examining how shortfalls in equitable sanitation and hygiene access for people experiencing homelessness fueled the worst multi-state hepatitis A outbreak in over 20 years and providing innovative public and private policy solutions. These interrelated strategies focus on harnessing systems thinking, unlocking existing but underutilized infrastructure, leveraging healthy planning tools, and strengthening social protections for people experiencing homelessness. In the remaining time, I'm going to take you through some of these promising solutions, but if you want to learn more, you can view the full issue brief on our website, and I'll share the link to our website at the end. Although international treaties have long recognized sanitation and health as basic human rights, the U.S. doesn't, and so rights often go unrealized. Legal interventions designed to strengthen social protections are key to the enjoyment and enforcement of these rights. For example, 4 states and 1 municipality have adopted a homeless bill of rights, which can explicitly safeguard existing civil rights and secure new legal recognition of human rights to sanitation, hygiene, and housing. And in fact, 2 such laws have included an explicit right to sanitation. In addition, 16 states have adopted restroom access laws for individuals with chronic conditions like Crohn's disease. In these jurisdictions, retail entities with employee toilet facilities must provide immediate access without demanding purchases or fees to protected persons. Jurisdictions can build on these protections to require businesses with employee or customer toilet facilities to open them to people experiencing homelessness and other protected persons free of charge. But how do we implement these newly recognized rights? And more importantly, how do we make progress in their absence? Well, a municipality can formalize this commitment to ensuring equitable service access and livable communities by developing a written sanitation and hygiene strategy with health at its center. A strategy adopted by a city or town council could articulate a vision for public sanitation and hygiene infrastructure in the community, contain an audit of the availability, maintenance, and accessibility of existing infrastructure, as well as an assessment of policies across sectors shaping livability and health equity issues around public sanitation and hygiene access. It could outline policy recommendations relating to the distribution, design, accessibility and inclusion, and management of infrastructure, and delineate an action plan with implementation metrics for change. Importantly, municipalities can require evaluation and reporting on progress and require producing regular strategy updates to ensure continued accountability and responsiveness. A municipal strategy can catalyze action in line with the 3 health justice commitments that I talked about earlier by expanding action beyond healthcare and advancing collective responsibility for health. But importantly, it can also serve as a powerful tool for community empowerment, including for those historically excluded from the policymaking process, including people experiencing homelessness. municipalities can weave participatory processes into each stage of the policymaking process, from design to implementation, evaluation. Well-meaning expert policies can miss important context and perpetuate social exclusion, but these participatory processes can empower communities to take charge of their laws and yield better policies. So I know this sounds, well, I think this sounds really great, but how realistic is this? Well, a number of municipalities in Australia, among other countries, have adopted municipal toilet strategies. As part of the local council's aspiration to create the world's most livable community earlier last year, Greater Bendigo in Victoria, Australia, set out to craft a strategic framework to guide the delivery and upgrade of public toilets throughout its jurisdiction. This timeline shows the process that they went through to shape their vision and objectives, design and placement principles, a public toilet toolkit with design decision-making tools to assist the council with determining future priorities, and a 10-year implementation plan. But perhaps what's most amazing about Greater Bendigo's public toilet strategy is the extensive participatory processes throughout its creation. The strategy was informed by a range of community activities, including stakeholder workshops with council members, residents, and business representatives, listening posts for engagement with the community, hard copy and online survey responses, individual written submissions, and additional engagement on Facebook. So this is a great example of a local government harnessing community power to arrive at policies for all. Municipalities can also incorporate sanitation and hygiene into healthy planning efforts. They can incorporate related objectives into their general plans, which guide local planning and development activities. They can leverage their zoning authority to require or incentivize the development of health-promoting public sanitation and hygiene infrastructure and ensure that they constitute permitted land uses. And they can build on momentum from the Complete Streets movement, which advocates for the design and operation of streets that are healthy, accessible, and safe for all, including pedestrians, cyclists, motorists, and public transit users, regardless of age, ability, income, or race. Governments can prioritize public toilets, hand sinks, and showers as key pedestrian and public transit user amenities. But it's not all about government policies. Restaurants, retailers, and coffee shops often have toilets for employees and customers, but close these resources to the greater public. If we want businesses to do something different than business as usual, we can provide incentives for them to do so. Through one such model, Net Toilet, over 200 municipalities in Germany and Switzerland pay businesses between 30 and 100 euros per month to make their toilets public. Participating businesses post the Net Toilet sign in their windows to indicate that their toilets are free and open to all. Bremen, Germany spends 150,000 euros annually, just 100 per month to each of 125 participating businesses to maintain its public toilet network through the program. An equivalent, exclusively city-run system would cost it approximately 1.1 million euros per year. So for jurisdictions concerned about the costs of creating and maintaining adequate, safe, clean, and accessible public toilet resources, even despite potential cost savings across sectors when we look at downstream healthcare costs and law enforcement costs, public-private partnerships can be a really powerful and cost-efficient strategy to dramatically and rapidly expand public access to services. If you're working to advance equitable sanitation and hygiene access in your community, or more broadly to advance health justice for people experiencing homelessness, I'd love to hear from you. You can reach me directly at my email address listed here. I also encourage you to visit our website at networkforphl.org to join the network, submit requests for legal technical assistance, access public health legal resources like the issue briefs that I mentioned, and learning opportunities like this webinar. Finally, I'd like to thank Walter Johnson, a phenomenal JD candidate at Arizona State University's College of Law, for his extensive research assistance and contributions to this project and presentation. Lauren Dunning for serving as a partner in thought on these issues. Greg Spiegel, as well as the Greater Los Angeles Central Providers Collaborative, Skid Row community residents and partners for their groundbreaking audit and advocacy on the public toilet access on Skid Row, and Lindsay Wiley for her incredibly formative thought leadership on health justice. Thanks, everyone, and over to Greg.
Thanks, Madeline. So first I want to say, let me get my slide up here. There we go. So the public toilet audit we did was a community collaboration and included lots of people, and I'm speaking here mostly because I'm a lawyer and this is law-focused and lawyer-type focused, but it could have been any other collaborators who could have participated here, and so it was really a group project. The people involved were Skid Row stakeholders of various varieties. Some were people with lived experience of homelessness. Some were housed residents of Skid Row, some longtime community row activists, community organizers. We had some homeless service providers, some housing providers, and then we had some volunteers who maybe lived downtown or nearby who provided like some professional expertise, like an architect, we had a photographer, a poet, a designer, and an artist who helped kind of make the report come together. Several people, many people fit into several of those categories. So we had a diverse group. And why did we focus on toilets? It wasn't really, to be honest, about hepatitis A. In fact, hepatitis A wasn't in the news until after the report came out. And it really was hepatitis A was a way to get more attention on the issue that we had already started on, which was lack of access to toilets. I mean, there are certainly horrible living conditions in Skid Row with little access to public services. People are vulnerable to the spread of disease, but that wasn't the motivation for it. As a group, we talked about this endlessly. It was really about the lack of access to toilets is really a denial of the personal dignity that we all have. The emotional toll it takes when you can't see to the most basic necessities of your life, that's what we wanted to address. That's what we saw as the underlying most critical issue, is just because you couldn't afford to pay for housing in a failing housing market doesn't mean you shouldn't be able to have access to such a basic necessity. And the impact when you don't have that access is counterproductive. People are dirtier, they feel worse about themselves, they're less able to get out of homelessness. So not only is it out of compassion for others, but out of practicality, it makes sense to increase access to toilets. So that was our motivation for working on it. Let's talk a little bit about Skid Row for those who don't know it. It's a small area. It's like 50 square blocks. You can see a little map of it there. It's actually shrinking because of gentrification. Maybe it's down to 40 blocks or so. But it's a dense population there, about 10,000 plus people. It's majority African American, which is rare in the city of Los Angeles at this point. But there's a lot of homeless people, about 4,500, and about 2,000 of them are unsheltered. That's very high for the rest of the country. It's actually not as high as other parts of LA where 2 in 3 homeless people are unsheltered. But Skid Row is a home to a lot of the big shelters in our city. The other thing, when we talk about Skid Row and having community stakeholders, is that I am not part of the Skid Row community. I am a white male lawyer who works for a nonprofit that is in Skid Row, but that doesn't make me part of the community. And so in many ways, I was not an ideal facilitator of this group because of that. And those are challenges that in community collaborations we've got to deal with and overcome. And there were times where it really set us back. Let's talk a little bit about Skid Row's history here. I'm just kind of for other people's interest, but towards the end here, homelessness had been concentrated. It is an intentional strategy to contain homelessness in this part of Los Angeles so that the other parts of downtown Los Angeles could boom for businesses. And so they said, okay, we've got a lot of poor people downtown. Let's contain them in this small area, contain the shelter and services. So it was intention to concentrate homelessness in these areas. But as we got to the 2000s and businesses occupied most of downtown and they're looking for cheaper rents, they start to look over to that little reservation for homeless people they set up, and they said, the rents are cheaper there. We want to go over there. It's kind of like, set up a space for them, but then you find gold on that, and you say, oh, you can't be here anymore. And that's kind of what's happening now, and that's what's triggered a lot of the lack of access to resources, is to really push people out of there. So there are several attempts. In 2006, the city launched something called the Safer Cities Initiative, which was a zero tolerance for anything, including putting a cigarette down the sidewalk or taking too long to cross a crosswalk, all these kind of things. And for about 5 years, the Los Angeles Police Department just ticketed everybody to oblivion. One woman who sits on a street corner because she's mentally ill and doesn't have any resources, she had 60 tickets in 1 year that become bench warrants, that become things she cannot pay, that end up putting her in jail, which end up making her ineligible for the housing she needs to get out. So this has been kind of the approach to just get these people out of this area so that businesses can move in. A common battleground has been over access to toilets. They've appeared, they've disappeared over time. Let me forward a slide here. Okay, and so there is this history of lack of access to toilets, and so others have tried to attempt it. The LA County Department of Public Health did a report in 2012 about the terrible conditions they're calling for toilets. A really important stakeholder in the Skid Row community, the Los Angeles Community Action Network, did a report called the Dirty Divide, where they talked about not just toilets, but lack of trash pickups and things like that, that kind of, the lack of access to public services just perpetuated this idea of Skid Row as a, unsafe place, but it's really as a result of the lack of access to resources. So they did a report in 2013. So we're building on a lot of the work that came before, but hadn't resulted in enough impact. A little bit of the status quo in Skid Row around toilets. The LAPD and the businesses in the area are the predominant voices. They're the ones that influence most of the policies and the electeds in the area. And their attitudes towards toilets has always been, well, if you put a toilet in Skid Row, it'll just lead to crime. People will do drugs in the toilet. People will have sex and prostitution, or there'll be assaults. And the thing is, of course, those things exist everywhere, and crime exists in Skid Row. That we'd expect to be different in the toilets is kind of ridiculous. And so denying people access to toilets because crime exists is absurd, but that's the contention. The other thing people would say, well, if you bring toilets, it's going to attract homeless people to the area. As you can see the numbers, there's already 4,500 homeless people in a 50-square block area. They're coming, and they're not coming for the toilets. People don't become homeless so that they can have an access to a nice toilet. These are the kind of arguments that only exist if one doesn't consider the interests of the people directly impacted, right? These are businesses who are simply thinking about the inconvenience on themselves, and that has been our typical approach to access to public toilets. It's looking at what will that mean for not the people who need them, but for the people who might be inconvenienced by them. And so we wanted a report that actually was focused on the people who are being inconvenienced. Okay. So how does one start? There have been efforts before. There had been in Skid Row, the leadership of Skid Row often finds it difficult to, the head of the nonprofit organization stuff don't always work together. There's a big philosophical divide among the leadership. Some people, there are like charity organizations that are religious-based that believe in helping people kind of, to help your own soul and to do the right thing, and you help as much as you can. And then there are other people who are rights-oriented people who think people are entitled to the basic necessities, and those are often in conflicts about things like what kind of housing should be provided, whether you should condition housing based on ability to be clean and not take drugs or take your medications if you have a mental illness. So there's disagreement about all that stuff. And because of all that disagreement, we often limit our impact and power because the electeds who make decisions hear a cacophony of voices instead of a choir in harmony. And so if we wanted to make an impact on this toilet issue that had gone on for so long with little change, the goal was to have agreement across the board where we could all speak with one voice. And we could have worked on a lot of issues that are needed in Skid Row, but toilets were one thing that everybody kind of agreed from the homeless service provider side that was needed, as well as the residents, as well as the people living on the street. So there was broad consensus about this, so we thought we could kind of get our harmonious group together. But even with those good intentions, with a diverse group of stakeholders, with a community with a lot of experience of being exploited and disregarded, or people promising things and never delivering, the first step was really to build trust among people. And one way we did that was trying to establish some principles for collaboration, and that's in our initial meetings, talking about how we wanted to work together and the concerns people had about certain voices not being heard because they had lived on the street, or they were African-American, or they had mental illness, or whatever. And so we wanted to hear all that out and get all that down, and then have agreement that these principles we would brainstorm and come up with would be the way in which we operate our meetings and our work. And then it was something we could also point to as people joined us and said, this is the price of admission. You have to agree with these conditions, otherwise you can't work with us. You're welcome to do with that whatever you want to. You can go advocate on the issue somewhere else. But if you're working with us, this is how we're going to work together. So it was deliberately emphasizing collaboration. We had a membership committee that was tasked with kind of trying to figure out some barriers to people with lived experience of homelessness participating, or other people we want to encourage to participate who might find it difficult, say because we only spoke in acronyms, because we, talked about stuff that we know in our work that make it, boring for other people, or uninteresting, or alienating. So we thought about how we talked and how we shared. We wanted to provide lots of opportunity for people to say what was and wasn't working with them, and making it an organic document that would change over time. And we wanted to really dramatize the lack of access to public toilets and not homelessness. So when we thought about what photographs we were going to use in a report, we wanted no identifying photos of any person where you couldn't tell. We want to make sure all the photos were in Skid Row. And we really wanted to make sure that whatever we were doing, it didn't become about individual agendas or settling scores, but it needs to be, is what we're talking about going to get more toilets in the Skid Row community, or isn't it? And just shut down other side conversations, which there were a lot of. And here's just a look at our principles document. And I talked about most of that. Another important thing was to share credit. Really not worry about who did what or how much they did. Everybody was a volunteer there. If somebody wanted to work on something, we figured out a way to make that happen. And if somebody didn't, they weren't obligated to. And however much anyone did, we weren't counting it. You got to put your name on the report if you wanted it on there. And so we didn't. We just put it alphabetically, no roles assigned. You got to decide how your name looked. That was very important to people who had often felt overlooked, or where other people took the credit for their work, and seems to be a really important issue in disenfranchised community with a history of being overlooked. Okay. So what we wanted to do was really document the lack of resources, and not simply have stories or anecdotes, but really try to say, well, how many toilets are there in a way that really couldn't be contended? And so we can argue about a lot of things, but we want to establish like the baseline for the understanding of how much is available. And so we asset mapped Skid Row. We had, I don't know, like 15 of us, maybe 18 of us who walked around Skid Row with the toilets that were advertised as publicly available. And at 3 different times per day, in the morning, midday, and night, we audited them based on criteria that we had. We had checklists and for cleanliness and for signage and access. Were there security guards? What was there a requirement to entry? Was it discouraging people who looked a certain way from entering? All that kind of stuff. And then we compiled all that data. And what we found was that the most compelling fact we found is that overnight in a community where roughly 2,000 people would need access to toilets over 50 square blocks, there was only one place that had toilets available overnight, and it only had 9 toilets available. That is compelling in itself, but I don't think most people, we didn't have a lot of understanding about, well, what should that number be? And I mean, there's not like a common understanding of it. So we tried to kind of come up with some kind of standard that the expectation should be, and we kind of looked around in Bend for a while. We looked about in businesses and employment, like how many, there's a standard for that, and it's something like a toilet per 50 employees, and schools have it, but that standard's pretty high. And somebody came up with, well, what about United Nations? The United Nations has, on a couple of occasions, gone through Skid Row and done some reports, and so we looked around, and somebody found that in a long-term refugee camp, so, you know, we're the city of Los Angeles, a capital of the world, the refugee camp standard is 20 people per toilet and no one living further than 50 meters from a toilet. Well, we needed in Skid Row about another 164 toilets to meet that standard. So we were far off a refugee camp standard, and we liked the idea of the headlines we could see. Los Angeles doesn't even meet refugee camp standards. And so we went with that standard. The interesting thing was nobody ever questioned our numbers of toilets available, and nobody ever questioned that standard. It just became what the media adopted. I think because there had been a vacuum, people don't know how many toilets there should be or anything. We provided a standard, and the world just kind of said, okay, that's the standard. So there's a real power to framing it in a compelling way and having numbers. They just get adopted, and that becomes what everybody's talking about, and then it's about how you address it, not about what the gap is. So that was a nice benefit for us. The other thing, the mapping process itself ended up building a lot of camaraderie in the team because you're going through these experiences. And I got to say, I walked through Skid Row a lot, but the toilet auditing day was the most depressing day of my 23 years of working in legal services. And it made me feel a great more deal of empathy for the people there, but also with my colleagues as we kind of went through it together. It was an experience. We also wanted to be sensitive to the nonprofits that we were auditing and very critical about their toilets, but we didn't want to out them in the report because then we make enemies. So we wanted to work with them and give them the results of the audit in private so that, and brainstorm with them about how to address their shortcomings rather than kind of out them in the public. And really our target was the public entities that should be providing resources, the county and the city. Then came drafting the report. That was something I am good at drafting and writing words, but not at putting compelling looks together and things like that. And we had a great team that did that. We had an architectural firm that did the design layout, and they're amazing people. We had an amazing photographer. We had a poet. We had artists. We had people doing first-person narratives. We wanted, when decision makers read it, we wanted them to have to deal with the idea of a person who can't access a toilet, to think about that, to put themselves in that position right away, because the electeds and their staff and the agency folks often are removed from the individual. So we really wanted to try to pull on the heartstrings. What would that feel like for them or a member of their family? So we tried to tailor a report to really pull heartstrings in that way. And in the report, we had, our findings, our recommendations. It was kind of split evenly between the two. But really the recommendations, the most important was highlighting the need, and we had some specific recommendations, but it didn't have to be our recommendations, our solutions. If there's better ideas, we were all for it. But there were principles around our recommendations that we wanted. We wanted the toilets all to be, provide safety, where people felt safe being there. And that didn't just mean in threat from others, outsiders, but not feeling threatened by the people who were running the toilet facility. Many people felt with armed security guards barring entry, it felt unsafe entering. So we wanted safety. We wanted them to be maintained and supplied with resources. We wanted it to be accessible to people with disabilities. There needed to be privacy. That's essential to the dignity. And they needed to be clean, also essential to dignity. So we articulated that out because we wanted to make sure that whatever solutions came forward, that was a standard being applied to them. And then as we issued the report, it then turns from, auditing and drafting and compiling to advocacy and framing and pushing. And so we pushed out to the media and got a lot of really good coverage, the kind of coverage we really wanted to see, headlines that were talking about refugee camp and talking about the big disparity between the UN standard and what toilets were available. A lot of people came down, reporters, radio stations, things, to Skid Row and start to look in places at toilets and not what they never have done before. So it got a lot of attention. We focused our advocacy on the county and the city elected officials because they really hold the purse strings about how priorities are acted on, and whereas the government agencies, as Madeline was saying, it's not clear who's in control of what, so we went straight to the electeds because they could drive it. As we're advocating, No Place to Go, our group, didn't really control the solutions that came out. The mayor's office had set up a separate group of Skid Row stakeholders to work with, and that was really fine with us because if they were working on the right solutions, that's great. And a lot of our members were part of that group. So the city really wanted their own kind of thing to create and their own stakeholders, and they had enough of the right people there to drive the process. And again, we didn't want to have to be proprietary about, where the solutions came from. So the solution that came out of that process with the mayor's office and the city, it was the Skid Row Refresh Spot. And the mayor was collaborating with a group that calls themselves the Skid Row Community Impact Coalition. As I said, some of our members were part of that group. Many other people were also part of that group. But they came up with a collaborative design approach, something that really addressed community needs that would not have come out if it was just the city alone. So the basics are that there are 3 trailers. Well, this is not what it is right now. It rolled out, a stock rollout in December, and now they're amping it up and hope by the end of July to meet these aspirational goals, which they expect to hit, which is 3 trailers with 8 to 12 toilets and sinks in it. In one trailer, a second trailer that has 8 ADA compliant toilets and showers, and then a third trailer that has 12 washers and 12 dryers. So among those 3, that addresses a lot of the day-to-day needs that people have. There's ramps for wheelchair access, on-site. You can get actual on-site supportive services if you want them, or referral to them, but they're not required. It's not mandatory. You don't want to set up any barriers for participating for anybody. They can be referred to the coordinated entry system, which is the effort to assess people and start to get them into permanent housing, but you're not required to. The environment is placed with potted plants. There's shade. There's music that people get to give input into about what music's played, and significantly, there's not security, but there's public safety. So the people there, there's a group that's hired. They have no uniforms, no badges, no guns. They look like the people from the community. Several have lived experience, and they're really trying to make it a good place to be rather than a place where you're watched and people are suspicious of you. A lot of the service providers and the people who are maintaining it are from people with lived experience, so that was a really important part of it. And the LAPD is not really playing any part of it. occasionally patrol or slink by the opening, but they don't come into the facility. None of those things would have happened if it had been just a city-run thing. Our challenges, however, is it's taking a long time to roll out. There's unforeseen complications in launching these things. Our hope is that you do it right one time and it's easy to do other times. And all along we've been saying one is not enough, we've got to have many more, but really the groups burn so much energy in launching this one thing. The energy to keep going has waned, and so we really have to fire it up again if we're going to do it. And anyway, that's the no place to go approach. So now I'd love to pass it on to Lauren, who can talk about, as I'm trying to pass this to her, talk about the County of Los Angeles.
Great, thank you so much, both Greg and Madeline. And now I am going to go ahead and get started talking a little bit about public hygiene facilities and specifically identifying policy levers and developing interventions. So as was mentioned previously, I'm from the LA County Department of Public Health. I'm a public health practitioner, and like many public health practitioners, recently because of the hepatitis A outbreak in California, because of necessity, we've been taking an increased look at this area of hygiene and access to sanitation. And I know that many people have been working on this for a long time, but I'm relatively new to this, and in order to be able to work effectively and be an effective partner with community and public works, I really needed to take a look at sort of how to learn from, in a frameworked way, the work of others, so that I can figure out what resources we have and maybe how to move forward in a coordinated way. And so I'm going to be focused on that, and now I'm going to talk a little bit specifically about hepatitis A in LA County. So as we've mentioned, in 2017, California experienced a hepatitis A outbreak. San Diego had the highest number of cases, and with San Diego being our direct neighbor, we knew it was really critical that we engage in early planning and intervention to handle this issue. And so by the end of the winter, LA County had 37 cases and 0 deaths. And our at-risk population in this outbreak were people experiencing homelessness, which in LA County overall, there are more than 53,000 people that were counted during our last homeless count. And additionally, recreational drug users, MSM, or men who have sex with men, and particular workers serving at-risk populations were also at risk and were recommended to receive vaccination. So moving on to the next slide, focused on our response. During our outbreak response, vaccination was critical for prevention, and we mobilized heavily on this issue and administered or distributed over the winter and spring more than 36,000 vaccines to at-risk populations. And we also conducted educational outreach, doing more than 500 events. And additionally, we coordinated with our partners, including Public Works and a variety of city and county and community agencies, to work to increase access to public hygiene facilities. And this was a multi-agency, multi-pronged approach to public hygiene facility access aimed at preventing more hepatitis A cases and potentially deaths. And so to begin this work, LA County Department of Public Health, along with our partners, performed an assessment of homeless encampments in both unincorporated areas and in cities. In doing so, we were able to assess existing infrastructure and also to identify potential locations of greatest immediate need and also areas that were feasible for placement. As was alluded to earlier, just seeing a space of need, sometimes there's a lot of jurisdictional issues around space that need to be clearly worked through, because in a county you have space that's unincorporated, that's under county jurisdiction for public works. You have cities that are in control of their own space, but that public health serves as their health department. There's also other types of properties like Army Corps Engineer for the riverbeds. And so it was important to understand everyone that possibly had a jurisdictional role and make sure that we were working with and communicating with them effectively. In response to these findings, we were able to deploy mobile toilet and hand washing facilities in county unincorporated areas to some of those areas of greatest need, and also to work with and encourage our city partners to do the same within their jurisdictions. Additionally, we worked with existing organizations to pilot access to mobile shower facilities. So looking further at the placement of these facilities, you'll see that we were able to, during the outbreak period, place 4 toilet and hand washing facilities in unincorporated areas. Those facilities were mobile facilities that included a double unit toilet, which is 2 toilets, a wheelchair accessible toilet that included a sink, and there were also 2 sink stations at each site for a total of 4 sinks. And like I said, these were deployed to areas where there were a concentration of people experiencing homelessness in the area, and where there was a lack of bathroom access. You'll notice that 3 of these are locations that are on or near flood control channels, and so we were able to place them there because there was some available space, and then another one is on unincorporated county property. So moving on to just looking at, just to give people a ballpark and understanding of placing temporary facilities, you'll see that our total monthly cost per site is about $25,000. And that's, depending on your perspective, expensive or not expensive, but you'll see that the greatest cost is around security and monitoring for the spaces. And we can talk a little bit more when we get into policy levers about some of the models for providing long-term and short-term services to continue to run these facilities. So one of the important things when you're talking about placement of facilities is to figure out, how to encourage people to align their interests to increase access to public hygiene facilities, especially for those disproportionately impacted by a lack of access, and that includes people experiencing homelessness. And, this is all sort of a part of a dialogue on how we, as the larger Southern California entity, encourage an increase in available housing for people. And one interesting example of working to align interests I found was the United to End Homelessness campaign launched by the United Way in Orange County, that is to mobilize citizen engagement, acknowledging that everyone needs to work together effectively to end homelessness. And that campaign involves a citizen pledge to support these types of efforts. And so that's just one example of thinking about how to encourage people to think about this as a community effort to take care of community needs. So moving on to talk a little bit about the mobile shower pilot that was taking place in unincorporated LA County. Our Department of Parks and Rec at LA County entered into agreements with a private nonprofit that has mobile shower facilities called Lavame to enable the deployment of a mobile shower in the Whittier Narrows Recreation Area, a very large park with space and existing bathroom facilities. And thus far, there's been an average of more than 100 individuals utilizing the services provided during the shower pilot hours. And not all participants are utilizing the showers, but the showers do help to generate interest in the other engagement opportunities at the site. Those include services such as homeless outreach teams, Department of Public Social Services to encourage people to enroll in CalFresh and other available programs, and additionally Public Defender for criminal record cleaning, and a whole host of other organizations participating in providing wraparound services to ensure that this pilot maximizes impact. And it's important to note also that there have been no security issues thus far with that pilot. And so now to move on past some of these LA County examples, to talk a little bit about an overarching framework. So in looking at the issue of public hygiene facility access and trying to develop and implement policies, there's a general approach, being a health and all policies approach. There's a timeline modality involved, looking at both short-term and long-term interventions. And then finally, looking at what policy levers are available regarding how to design these interventions. And the nice thing about policy levers is often they're the same for multiple different types of interventions. And so while my background is not in public works or sanitation, I'm able to draw upon my work around trying to create livable active places. And some of those policy skills are portable to thinking about existing infrastructure and how to build upon those efforts. So moving on to talk a little bit about the importance of a health and all policies approach. This approach infuses consideration of health equity into design, implementation, and evaluation of policies across sectors. And it promotes cross-sector availability for health, especially when rooted in law. And I think that what Greg was speaking to earlier speaks really clearly on that when we are doing assessments and interventions, it's really critical to take a health equity lens as we begin this work. And our timelines for doing this work ties in to that concept because short-term approaches allow for targeting of resources to address the disproportionality and the impact of that disproportionality on people experiencing homelessness. And then a long-term approach addresses the sustainability issues that were highlighted earlier and allows us to harness existing planning and design processes to address the needs of entire communities holistically. And so some examples of thinking about short-term versus long-term interventions, right? Short-term interventions can address disease control and prevention, for example, for hepatitis A, and also address serious gaps in infrastructure, like what was just discussed about Skid Row. From a long-term perspective, we're talking about using existing zoning, neighborhood planning, park planning processes to figure out how we can leverage them to ensure access to public hygiene facilities for all. And also it ties into placemaking efforts around creating communities that are walkable, livable, bikeable, accessible. And so with those ongoing processes, inserting the ability to talk about public hygiene facilities is critical as we look towards sustainability of these short-term proposals that provide a bridge to those long-term efforts. So now moving on to our policy levers. So I've gone ahead and broken out our various policy levers into location, infrastructure, and services. So to start, on location, there's a variety of property types available in public property, private property, public right-of-ways, and government facilities. And so looking at property broken down this way or locations broken down this way can help with asset mapping and trying to understand where the best approach is to maybe utilize multiple interventions. So just to give an example, public property locations are parks, beaches, transit stations, empty government properties that might be suitable for temporary facilities to be placed. When you're talking about public right-of-ways, you're talking about sidewalks or sidewalk parkways, and many locations in the U.S. Have installed these types of permanent facilities, including San Francisco and New York. And San Francisco particularly has a large project with JCDecaux, which provides the advertising you can see pictured here on this facility. And so those are in public right-of-ways. And then there's also, existing government facilities. Those are another type of property beyond, existing lots or parks or spaces. and there's many, many buildings out there, and figuring out which ones might be suitable for access is a positive thing. And just to touch briefly on private property, Madeline had mentioned efforts in Sweden and Germany, but also with Starbucks recently discussing about opening its bathrooms to anyone who seeks the key. This could be an important opening to a dialogue with businesses about their role in the community and access to public hygiene facilities. So moving on now to talk about another critical policy lever, which is infrastructure. So first, we can look at existing. Right, examples of using existing infrastructure are keeping already installed, already existing hygiene facilities open overnight or for extended hours. So for example, that's taking place in LA with some of our bathrooms at LA City beaches are staying open 24 hours. Additionally, the Department of Public Health is working on a safe parking lot pilot with a number of partners to enable people living in vehicles to park overnight at some of our health facilities during hours when they're not in use, and that involves also being able to use those hygiene facilities that are already there. A number of cities have also worked to install new infrastructure in response to the need for bathrooms. As mentioned, a number of cities have JC2Co automatic public toilets connected to city sewage and water. Another example is San Jose. Some cities are using mobile facilities, such as pictured here, the city of Denver's public restroom pilot project. They have 2 mobile trailers that move around the city to find areas of need. The infrastructure itself has a lower cost, initial cost, because it's not connected to water or sewer. And then additionally, there's temporary infrastructure. So San Diego had temporary hand washing facilities placed around the city, 40 of them, during the Hepatitis A outbreak to address the deep need for hand washing. And so taking a look at all these multiple ways to look at some of the infrastructure available in communities can help us come up with policy options for moving projects to increase access to public hygiene facilities forward. And then finally, to touch on the final area, which has been mentioned by a few others, around services. So some of these permanent sites that are in public right-of-ways actually have a self-cleaning function that has some automated cleaning associated, but other sites would need maintenance from cleaning to emptying of portable facilities. As mentioned, there's the issues of staffing and security. Governments can utilize existing staff or contractors. As mentioned, the Skid Row Community Refresh Spot had ambassadors at the site, and San Francisco, their Pit Stop program for their sidewalk facilities contracts for maintenance and attendance with local nonprofit workforce development programs to provide staffing for those facilities. It's also important to note that an audit has found that toilets are used more when the attendant is not an armed security or law enforcement official. And so I think Greg talked a bit about the importance of that piece of the intervention to the community refresh spot and its importance in the community. So those 3 areas, but there's many more around how to ensure that we've planned for all the services needed around these types of facilities. And now finally, looking to bring all of this together into a framework. This grid here can help us look at how short and long-term interventions can be implemented in concert to leverage effort and build upon existing resources. And so short-term efforts can tie into long-term efforts, and also some of the assets mapped for short-term we can figure out how to leverage them into long-term, or you can build upon them to help increase community acceptance and engagement around creating communities where everyone has access to public hygiene facilities. And as a final note, as an overarching theme to all of this, we have our health and all policies about how we bring an equity lens to this work to ensure that disproportionality in access is addressed. And so I went through some examples on these, and this grid gives some of those location, infrastructure, services examples, and you can walk through them. So, for example, if you look at short-term location, you can say parks, parking lot, riverbed. You can look at the infrastructure types, including trailer, portable toilet, existing facilities, and then look at how services are getting done. So pretty much for each of these, you could put anything together and come up probably with a city that's done an example that maybe we can all learn from. So if you go parking lot, portable toilet, or trailer, and government services, you get what LA County is working to do at one of our beach parking lots to increase access to mobile toilet facilities during the evening when many facilities are closed. You can do the same thing for long-term, thinking about sidewalk parkways, permanent structures in partnership with community agencies. That looks like San Francisco's model, and maybe if you have the assets available or the political will available, you can look there. So this is just sort of a handy way to just start getting some ideas around working in communities to develop these interventions. And with that, I will go ahead and hand this back to our moderator, Corey.
Great, thank you. So I would encourage everyone, there is a Q&A box on the right-hand side of your screen. You might need to, these are the instructions, you might need to click on the tab to embiggen it if you can't see it. But please put your questions in there. Questions can be, select all panelists, even if you have a particular person in mind to target with your question. And I will make sure that the panelists see it. While you're doing that, I had a question for Greg, actually. I mean, I really liked your description of the process that you went through, and particularly its, the participatory nature. It seemed like you were very mindful of your role and the role of the people in the community. So I guess my, the question for you, Greg, is, what insights or recommendations do you have for other people in other communities who might be thinking about, how to go about having this sort of conversation and process in their communities? What recommendations or sort of lessons learned did you take away from that process?
I appreciate that, Corey. I think it's important to have, in whatever we do, diverse participation, not for some checking the box kind of thing, but because everybody brings a piece of solution, and the solutions are better when all kinds of people who are impacted are at the table. And so I've been part of many advocacy efforts where it's what I think people need, and I'll get a law passed or whatever, and then nobody's there to benefit from it because it's not well crafted or well designed, or nobody was asking for it in the first place, and it becomes kind of a self-indulgent effort. And so all of us were committed to this, trying to make a difference in the community, and therefore we needed people who would be impacted to help design it. And the designs will be better because of it. And the Refresh Spot is really kind of an oasis within Skid Row with that. And it's been, some of the concepts there helped inform, I think, Lauren's efforts in the county. And so if we want good results that will make an impact, we have to include all kinds of people who would benefit from it.
Okay, and a quick follow-up there, Greg. How did you go about, really engaging folks from the community and, sort of showing them or convincing them that, like, we really do care what you think. We really do want, you're not just window dressing here. We really want to make sure that your voices are heard. Do you have any kind of specific suggestions for how folks could go about, really meaningfully engaging with people in the community?
Well, so first, Inner City Law Center, my organization, has been in Skid Row since 1980, has advocated for people's housing issues and things like that. So we're not helicoptering in exactly from outside. So we're known, we're on several community participation committees, and we know people. And then, but even then, one is still an outsider. One still drives to one's home at night, and it's different than being in the neighborhood. And so you start by talking to people that you see as, leaders in the community, and start talking like, what do you think is important? What do you think that matters? Rather than pitching the idea to everybody, start to, ask them questions about what they want, what they need. What do you think about collaborating on this? Who would need to be involved? And it's really about asking questions and listening and stitching ideas together with the participation of everybody else. And many times in my past, I've thought I had the right idea and forced it down people's throats, and it never works.
Yeah, thanks for those insights. Lauren, I have for you kind of a specific question from one of the participants, which is just a request to talk about how you did outreach as far as the hepatitis A vaccine. What was your process of reaching out to people and offering the vaccine and answering concerns that folks might have and that sort of thing? To the extent that you know, I realize that you're an attorney and not the medical professional.
Well, thank you, Corey, for that question. And that is part of the answer, which is in LA County, we are really well equipped to mobilize in response to communicable disease threats. And we have a community health services section, and that means we have public health nurses that are already working in communities at the community level, are well connected to community organizations and also people in the community. And so we were able to mobilize by reaching out to those existing community contacts to offer, to convene presentations and immunization events, and to actually go on site to conduct outreaches. And that's oftentimes how we did that. We went on site to work directly in the communities with people so that we could meet them where they are. So, for example, on a number of occasions, we received notification from community groups or elected officials that, hey, I think this is an area that would really benefit from you having an event. Can you go down there with, vaccine in your essentially refrigerated cooler? And that's how that worked. And so having ongoing contact with the community, but then mobilizing and offering and reaching out and publicizing those outreach events for people. And so in addition, and I didn't put them on there, we had those purely educational events where we were going out to provide people with prevention information. And then we had our vaccine outreach events, which were part of how we got more than 33 vaccines out into the community. And so there was sort of a two-piece outreach involved.
Got it. Thank you. So this is another great question from a participant. And I think maybe, Lauren, if you could take this first, and then Greg, if you could answer the same question. And so the question, let me paraphrase it, is just kind of, what were we're all lawyers here on the as presenters, but we're sort of, maybe perhaps policy people who are trained as attorneys, but the question is, what legal issues did you run into as you were planning and implementing these projects? And, what role do lawyers play in the process in their role as attorneys, as opposed to sort of as advocates or as policymakers? Lauren, if you could address that first, and then Greg, if we could just move on to you.
I'm sorry, Corey, I didn't catch the last part of that. Can you say that one more time?
Yeah, sorry. So the question is, I guess, is just from a very traditional, like, sort of legal standpoint, what laws, regulations and those sorts of things needed to be considered or navigated as you walked through, both of these processes. So for you, Lauren, sort of the mobile, comfort stations, for example, or the hepatitis vaccine initiative. What if any, sort of, nuts and bolts, legal and regulatory issues needed to be navigated as part of that process?
Thank you, Corey. I really appreciate it. So I'll start first with talking about the placement of public hygiene facilities. So if you're talking about short-term interventions, a lot of the more legal work is around how to access property, right? What agreements are needed in order to do that? Who controls a particular property, working through the jurisdictional issues to understand who has responsibility or access for a particular piece of property. And so for those types of interventions, a lot of most of the legal work is around contracts, working through government processes, liability, that kind of thing. When you're talking about tapping into longer-term processes, it's assessing and looking at land use issues to find out whether there's any barriers in planning or zoning documents, whether there are things that could be changed to be more explicit about encouraging particular types of development that includes access to public hygiene facilities. And then there's also looking at the potential legal levers that are about how the government encourages or incentivizes particular types of public activities, or that it uses the ways in which it uses its own resources. And so those are just sort of a handful of issues, and I know there's a lot more, but even I myself am sort of new in looking at some of these. In terms of vaccines, hepatitis A is not a disease that would lend itself to some of our typical public health legal authorities, like, for example, quarantine and isolation. In our last major outbreak that was associated with measles, we were working on needing to create community distancing policies. That is not the case for hepatitis A, as it's a disease that's fecal-oral route, and so vaccine is available, and also there is effective prevention of transmission by hand washing, proper sanitation, et cetera. And so we were looking from a public health perspective at needing to mobilize more prevention and education and community resources than working more on the individual basis, as you sometimes do with particular types of communicable diseases like measles, or like we were working on with Ebola.
Okay, thanks. And Greg, same thing for you just quickly. Are there any sort of those kind of traditional nuts and bolts legal or regulatory questions that you had to be concerned with as you were, looking for sites for the bathroom facility and so on?
We didn't have those because we weren't specifically looking for the sites, but people did have to deal with those, as Lauren had talked about. For us, which was really kind of framing the issue, we needed to find that some kind of standard to say that the city and the county were not meeting, some legal frame to try to get attention around them. So we found that United Nations standard, not that it's particularly enforceable locally, but that was the most compelling. So it was really in a policy context. Although I do think lawyers who approach it the right way can really be helpful to these kind of collaborations, and the way that we frame things with an edge and with a point can be really powerful. So why it might not be traditional lawyering, lawyers are trained to make arguments, and sometimes that's a big help to these efforts as well.
Yeah, thanks, Greg. I completely agree with that. I think, you know, the lawyers, the public health lawyers on the phone will agree as well. So I want to go back to you, Madeline, and kind of, you know, you talked about some promising efforts from other countries. You know, you talked in particular about some efforts that have been undertaken in Germany. Clearly, we're not Germany, right? But what do you think are the key takeaways from, you know, successful, interesting initiatives that have been taken in other countries? You know, what can we learn from what other countries have done in this area? Sorry, Madeline, are you there?
Thank you. Sorry, I was double muted. Thank you for that great question, Corey. I think that a key takeaway from the issue brief is that there is no one-size-fits-all solution, and it's really important that communities are empowered to tailor solutions to their own context, their own political, policy, social, physical context. But I think that, you know, in terms of if there were one major takeaway from the efforts in Germany and Australia and, you know, around the world, it's that there is strength in collaboration, there is strength in collective responsibility. It's not all about government action. Private players also have a really important role to play and can be part of the solution. Community members have a really important role to play and should definitely be a part of the solution because of all of the important information that experts won't be privy to as individuals who aren't, you know, as Greg highlighted, they don't have that same lived experience of the issues that we're trying to address. So I think that, you know, the key takeaways from that range of solutions is that, you know, initiatives that look beyond simply healthcare, that enhance collective responsibility and collective action, I believe can work in any community. They just might look a little bit different.
Okay, thanks. Thanks, Madeline. I think that makes sense. And you know, so we got a question from a participant, and the question is, what is your advice for how to approach my local government on adding more public toilets? But let me, you know, let me ask in sort of a broader sense, you know, so I guess for any or all of the three panelists, you know, how do you go about building political will for change around this issue? You know, based on your experience, and of course every community is different, but are there some sort of, you think, overarching ideas or suggestions for creating the environment that is amenable to change and for actually achieving beneficial change around this issue? I don't know. How about let's go reverse order. So Greg, do you have any thoughts on that first, and then Lauren, and then Madeline? Any ideas on that?
That's a big question. I think change is about power. You can't, especially for communities that we're working for that aren't in power. So you have to assess what power do you have. And so we started thinking. We looked around and we knew we had to think about which electeds cared about this issue, how many electeds would we need to be able to get where we needed to be. So you have to kind of do a power analysis. And we knew there was a crisis, but it wasn't being talked about, so we needed to come up with something that would make the crisis talked about. So you do an audit to highlight it, and you do a report, and you get media coverage that's going to be targeted at the people who we felt like, based on our analysis, had to do something about it and would be held responsible. And we tried to think about the people who might be opposed and how to either marginalize them or align them to bring more power. So to me, it's all about, do you have enough power? And then it's about, if you do you have the right solutions that include enough, the right people's ideas? I don't know.
Okay, Lauren, anything, any suggestions or advice, particular to, especially particular to this particular issue of, providing sanitation and related services, to people experiencing homelessness. Is there anything that you saw from your perch that you think might be applicable to people who might, be trying to improve a similar situation but in a different location?
Yeah, I think always coalitions are critical, right? So having people from multiple sectors with various areas of expertise to offer their unique insights is always important. And on this particular issue, I think it was really important to have a number of people with not only public health understanding, but public works and a variety of other and experience working with homeless populations come together to come up with, feasible incremental solutions, because I think everybody knows that if you allocate a bunch of money, you might be able to buy a lot of infrastructure, but there have been pilots or examples around the country that show that just allocating the money and placing them might not have as positive of an outcome as you might like. And so really working through figuring out the different essentially interventions that can work together to create access that addresses disproportionality is really important when you're talking about public hygiene facilities.
Great, thank you. And finally, Madeline, any final thoughts on this question based on your research in creating the issue brief and otherwise?
Thanks, Corey. I think that what Greg said about building power, assessing power, is a really important part of this. Even if you're starting from a place of very little power, if you can approach unexpected allies like public works, like private businesses, and communicate why these issues are also important to them, I think you can really build collective power in unexpected ways. That coalition building is really important. But I also think that policy translation is really important. We have not as much, not every community has conducted a public toilet audit like we have from Skid Row, but we do have a lot of evidence on the importance of these key public health services to long-term population health outcomes. And we also very often have information about the costs of inaction and lack of coordination across sectors. And so I think, policy translation, taking that information and repackaging it in a really concise and accessible way for different audiences. The power of the op-ed, a scholarly article is really important for one particular audience, but, translating what is happening into op-eds that, that everyday person can access is also incredibly critical for building political will.
Great, thank you. I think that's a great place to end it. So I want to thank our three panelists and thank all of you participants for showing up today. And I'm going to very briefly turn it back to Charles, who is going to tell you how you can get those all-important CLE credits and tell you about where you can learn more about this and even meet some of us in person and talk more about these really important public health law issues.
Great, thank you, Corey. And thank you everyone for your participation in today's webinar. And thank you to our panelists for presenting today. I learned a lot and I know our attendees did as well. So just a few final notes to all of our attendees. You will be receiving an email that will have the video playback of this webinar when it's available, as well as a link to our brief webinar survey. We really value your thoughts about today's webinar and what topics you would be interested in for future webinars. You'll also be receiving an email from ASLME with information on applying for CLE credits for this webinar, which should arrive within a week or two. And finally, our co-sponsors for today's event, the Network and ASLME, are hosting the 2018 Public Health Law Conference in October in Phoenix, Arizona, which will include one session dedicated to health justice and homelessness that will be led by one of today's presenters, Madeline Morcell. So make sure you register for that conference. It'll be one to remember. That concludes today's webinar. Thank you all for attending and have a great rest of your day.